Thank you very much for the invite. I'm grateful that I can share a continental perspective as an ethicist on the topic of the conference, which would be conditions for corrosion. What can a particularly German perspective add there? The answer is, as anyone on this side of the channel may agree, that Germany has and is doing things differently. Not only in how they do politics, that they don't have humor, they build cars differently, and so they run their healthcare system with significant differences to the NHS system. And I'm happy to take the US perspective, as we only have half an hour, in the question and answer. So maybe one can learn from German strength or weaknesses of their medical system. Why compare it to the NHS? We could have compared it to other European healthcare systems. One reason is that the German system is somewhat of a hybrid between the state-run and tax-funded NHS system and the more privately organized US system. Therefore, I will start off with a description of the current German hospital system. I focus on the hospitals, not the private practices. And then compare it with the NHS and assess how the latter is perceived from a German viewpoint. Hope you don't take any offense on that. I will compare then their strengths and shortcomings from an ethical perspective, with a special emphasis on how those differences reflect on the professional identities of people working day to day in the respective healthcare system, with the effects you just heard in Warren's presentation on the US system. And finally, I will discuss what is most needed to improve the situation, so to speak, to end on a hopeful note. My focus will be on urgent demographical trends that further unsustainable corrosion with all its negative effects on professional identities of healthcare practitioners of both sides of the channel. So let's start with the German hospital system. Particularly after the COVID-19 pandemic, hospitals in the publicly funded, decentralized German healthcare system mirror the situation of those in the NHS. German hospitals are now increasingly having to deal with staff shortages, severe problems in allocating funding, and rather new development, more and longer patient waiting list, formerly unknown. Individual practitioners trying to, quote, act for the good find themselves in a seemingly intractable professional and ethical dilemma, namely, how does one deliver adequate patient care under increasingly imperfect conditions? We talked about that in nearly every conference speech so far. During the COVID-19 pandemic, which exacerbated pre-existing healthcare problems, the questions of professionalism and professional identity were often discussed in emergency meetings of what you call the Deutscher Ethikrat, the German Ethics Council. And the obligations of healthcare workers were addressed by ethicists as well as representatives of the German churches, which are members of that ethics council. And you ask yourself, why is that? Because churches are also a major stakeholder within the healthcare system, with 500 of the nearly 1,900 hospitals in Germany being run by Catholic organizations, while more than 200 hospitals are run by the Protestant organizations, similar to the situation we heard from Dallas, often directly run by the churches with a theological and a medical chief of staff. So, with a total of approximately 1.3 million employees, Caritas and Diakonie, the Catholic and the Protestant provider respectively, as welfare organizations, are among the biggest employers in Germany. 1.3 million in a population of 80 million are working in that healthcare system, which already give you a first hint of the economic problems. I will come to that. The largest provider in East Germany, in Mecklenburg-Pomerania, very small of the 16 counties, the largest provider is the University Hospital of Greifswald, which is not a very good sign if your largest economic provider is a university clinic. You should have normally have like firms or whatever. So if you do the numbers with me, and I'm normally teach a lot of business ethics, so I always come to numbers, but then I also come to the ethics, so don't worry. If you do the numbers, the leaving 1,200 hospitals are state-run, communal, or private. 37% of those are private, the rest are state-run. And I will return to the historical reasons behind these structures which have led to a current unsustainable oversupply of hospital beds, which may sound very weird to American or NHS ears. At this point, it's important to know that in their role as consultants to the German government, I talked about the National Ethics Council, physicians as well as theological ethicists and within the German Ethics Council put a special emphasis on concepts we discussed here all over in the conference. Justice, accessibility, enabling compassion in relation to the professional identity of healthcare workers. Much of their criticism revolved around the healthcare system failing to focus adequately and sustainably on those people who in Rawlsian terms would be the least privileged, i.e. the most vulnerable, that is, patients who do not receive the care they need. And after COVID was no longer declared a pandemic, the German government reacted to the strains placed on the healthcare system with plans to tackle those key challenges. Facing professionalized care in its decentralized health-insured funded system. Hospitals in Germany are often small, medium-sized, decentralized units. They are less specialized and therefore quite costly. And you double structures. The Ministry of Health currently proposes to improve hospital funding by reducing their number roughly by a third. That tells you how difficult the situation is economically. The key driver for this decision to start with the hospital beds is obviously the immense costs of the hospital system through its parallel structures. In 2018, Germany had the highest number of hospital beds in Europe, which is 800 per 100,000 population. In contrast, UK is less than 250. There you see, very different starting point, and you may end up with similar ethical problems. A possible model for coming reforms in Germany is not the state-run tax-funded NHS system, but the Danish system in which few central and specialized hospitals provide care for the entire country, enhanced by additional funding and full digitization. The crux of the matter is, of course, that a dilemma does not have a quick and easy solution, but rather is an ethical choice as to which is the lesser evil. Unlike more centralized Denmark, with a population of some 6 million, Germany in its decentralized structure has to organize healthcare for aging population over 80 million, with many people living in rural or socially diverse areas, where it currently proves difficult to even recruit doctors, let alone nurses, staff, midwives, let alone run an economically viable healthcare system. With this in mind, however, a perspective from a medical ethics does not per se involve comparing numbers of beds or patient data between the two countries, but it should try to analyze and understand the underlying historical and current economic factors causing worsening level of patient care through a misallocation of funds by too many shareholders. So what's the reason for those too many beds? To answer the question, one goes back to the 19th century to Otto von Bismarck, who on 15th of June 1883 introduced statutory health insurance with a state law for health insurance for workers. All workers and artisans would receive state health insurance for which they would pay the one share and their employer the other. So it's not tax-funded, it's employer-employee funded. If they became unemployed or sick, then the state would provide them with health care. Through this new system, Germany became the first country in the world to introduce comprehensive social insurance on a national level, a measure which Protestant as well as Catholic churches instantly supported. Today, nearly 90% of the population are part of the mandatory statutory health insurance program, which is not funded by the government directly, but by the insured and their employers. An additional 9 million people opt to pay for private health insurance, which reminds one of the American model. This means that in Germany, nearly everyone has a choice among the many state and church-run hospitals, which then bill their respective state or private insurance of the patient. The economic problem is the expansion of the healthcare system for a population that was growing after World War II, and therefore the now rising costs of the healthcare system, which not only must provide for an aging population, but which also finances these parallel structures. This is why you have all these beds. Historically, there has always been this duplicate structure of federal and community-run hospitals and communal clinics on the one hand and church-run hospitals, both Protestant and Catholic, on the other. And those denominational providers have their roots in the Christian social movement in the mid-19th century as an answer to what was called the so-called social question in era of industrialization around 1850. So most German towns built communal hospitals alongside existing Catholic or Protestant hospitals, where healthcare practitioners had to be members of the respective denominations. I was born in a Protestant hospital, and when I was born, I didn't know my nurses, but I knew they were all Protestant. No longer the case. After the Second World War, waves of migrant labor from the 60s onwards, the population became more diverse religiously and denominational boundaries became less important. By now, you don't have a choice. I'm not even sure if they are asking you in a Catholic hospital if you're Catholic. They're happy for any nurse coming through the door. Therefore, Germany remains the country with the highest number of beds per person, resulting in a world-class but extremely expensive healthcare system. The reason why and then you can ask, why does no one just reduce the beds, as the government now proposes? Simple, because it's not popular for any major political party to close a hospital. If you have a church hospital and a local hospital, not very specialized, 100 beds in your city or extended communal boundaries, and you have an election coming up, the last thing you want to do is close a hospital. So that's why no one is doing it. And this brings us from the problematic economics of German healthcare to ethical consequences of its rather generous policy, one that the pandemic brought to light as a catalyst. The strengths of that system are the choices it provides and the funding through stable employer-employee funded insurance system, which is less volatile than a tax-funded system and which provides healthcare for most of the population without any waiting lists so far. However, it is unsustainable for two reasons. If you think about that sort of funding economically. One is demographics and the other is less employment. What you need are a lot of young, employed people, healthy people, to finance the system, the insurance system. So the strength of the German system are the choices, as I said, but the weaknesses are these dependencies and the demographics you already know are not going in your way. A simple illustration of that point, the demographic one, is that in 1962, 6 employed individuals financed one retired person receiving a state pension. By 2021, they looked up the number. This number was down to 2 employed individuals financing one pensioner. So the whole Bismarckian system relied on a young, healthy population, which ours is not. This is a result of a negative demographic rate in which the strongest birth cohort, it's the year 1964. If you're born in Germany in 1964, you share that destiny with 1.36 million people. If you're looking at the same number in the year 2011, the number is 663,000, so a third of that. The consequences are clear for that employer-funded system. It is, in its current form, economically unsustainable. This development has been known for a long period of time, and it has, like most economic decisions, very serious ethical consequences. Because a common misunderstanding in ethics, as well as in the realm of criminal law, is that inaction is not legally or morally a wrongdoing, or not such a strong wrongdoing. A lot of people believe when they don't act, that's not an action. Yet, Wrongdoings can certainly result, as you all know, from inaction equaling an action. In our context, this means most observers will know, or could have known, and that's enough, that the current healthcare system is unsustainable. But since reunification in 1989, and increasingly during the last 2 decades, there has not been the political will to make significant changes. That is, cutting the number of hospital beds and putting clinics together. And as I say, the reason is not municipality and much less a church organization would voluntarily close a church hospital. Not even when 500 instead of 800 beds per 100,000 inhabitants would suffice, and the freed up resources could be used for investment in creating a more equitable and sustainable healthcare system. The question that forcefully arises is, so what should we do about it? And this echoes Immanuel Kant's fundamental question defining ethics, which is, what shall I do? He doesn't say, what shall we do? He also doesn't say, what shall the state do for me? He says, what shall I, singular, do? The ethical question, or more precisely the ethical dilemma, is that most parties involved, in and outside the churches, have known all of this for a long time. Instead, they let the state insurance system accumulate more and more debt and produce more and more exhausted healthcare workers. The concept of sustainability, and this is where I'm heading, and that's a concept that speaks to Christians who worry about creation as much as to secular people. And that's a good starting point, I think, in order to motivate someone to change. The concept of sustainability is not only economically but also ethically relevant in this analysis, which comes to the conclusion that the German hospital system, as it's run today, will simply be overwhelmed if it remains unchanged. Interestingly, the original concept, when you ask yourself, where does that come from? You have an English word, to sustain, and the German word Nachhaltigkeit. To sustain, Lateinisch sustinere, to be able to see a process through. Are you able to sustain your speed when you're running 200 meters? German word is very different. It's called Nachhaltigkeit. And at the moment, it's very popular. We have a green government. Nachhaltigkeit is in anyone's mouth. The issue is, where does it come from historically? It comes from Hans Karl von Carlowitz, who argued in Silvicultura Economica, 1713, that one has an economic as well as an ethical obligation to replant trees that have been felled in a forest. He was a forestry and mining administrator in Saxony. And in the 18th century, the mining industry had an insatiable demand for timber to prop up their mining tunnels in order to exploit silver and coal at the border of the Czech Republic today. In other words, the responsible use of resources has not only economic but also grave ethical implications, whether in forestry or healthcare. If one funds 800 beds while 500 would do, then money is wasted. Or if you're looking at my very ugly glasses, $1, you know, Lidl, the supermarket, if they're on a special, they are $1. I buy 10 of them because I always leave them somewhere. On Monday, I will go to Fielmann, which is a German optometrist, and I've ordered via my state insurance 2 new glasses, and they will be costing £750, and that will be on the state insurance. I would say if that is not an ethical issue in the choice of what you're doing, what is? And that's the same with the hospital beds. Well, this is more interesting because it's, so to speak, a medical device. They always say it's 2.0, 2.5, 3.0, and then you buy it for $1. Looks ugly, but it works. So if you let that system become chronically underfunded, and if these structures are left to deteriorate instead of being strengthened, then this will have an acute economic and ethical impact related to the people who make these choices, because they all know. Like me buying the other glasses. From professional identity to personal quality standards. This diagnosis of the German healthcare system is multifaceted, and in terms of medical service, with its overcapacity, it still produces high-quality healthcare, because the 1964ers are not yet pensioners. When they are, it's game over. And in terms of, and then you come to the ethical consequences. In terms of justice, present and future generations will most likely not receive the same level of health care than their parents enjoyed. Or in the words of Ezekiel 18, the parents have eaten sour grapes and the children's teeth are set on edge. The economists would say that resources were used unsustainably and were unable to perpetuate the Bismarckian system. The Christian ethicist would add that future generations suffering from this are relevant stake and shareholders when it comes to sustainability of the healthcare system, which they will one day inherit. So, comparison to the NHS, as time flies, I make this short. The analysis brings us to the comparison of German healthcare system with the National Health Service health services from a German perspective. The NHS is seen, it's a well-known name, brand name in Germany, they would know what that is. The NHS is seen as iconic, one committed to its core principles of providing, quote, healthcare that is comprehensive, universal, and free at the points of delivery. But at the same time, it's also perceived as a system in permanent crisis, as the numbers of untreated patients on waiting lists seem for a foreigner who doesn't know waiting lists, or long ones, alarming. Life expectancy in the UK has decreased slightly in recent years, and doctors are quitting in large numbers. Just to do some numbers out of the Economist Intelligence Unit, in 2023, the 75th anniversary of the NHS, over 7 million people were on hospital waiting lists. While according to the Economist, UK health outcomes lag behind those of its peers. Among 18 rich countries, Britain has some of the worst 5-year survival rates for killer diseases such as lung, colon, and breast cancer. And a report in 2020 by the National Audit Office, which scrutinizes public spending, found that across the OECD, a club of mostly rich countries, Britain invested the least capital per person in healthcare in 2015. Additionally, with only the mentioned 250 beds per 100,000 population, Britain has one of the lowest number in Europe. All single data, and you have to do a much more solid economic analysis to back it up, but you see where the journey goes. In terms of morale among healthcare staff and the future planning of NHS services, in a recent study, the Commonwealth Fund wanted to know how many primary care physicians intended to stop seeing patients within the next 3 years, and came to the somewhat, for me, alarming figure of over 60% of UK doctors above 55 and even 20% of those under 55 who want to stop business in the next 5 years. In Germany, those numbers were 40%. In Holland, again, 20% lower. So you have a big demographics problem among your among your doctors and nurses. In summary, so this was pretty quick. With an aging population and increasing demands for tax money to fund the NHS, the current healthcare system seems unsustainable, like the German one. And similarly, this development could not have come as a surprise to anyone, as the demographics of an aging population are also similar to ours and long known. This implies that the unsustainability of both systems remained rather predictable, and that's important ethically if you come to the question who takes responsibility. So both systems are struggling for different reasons, one of oversupply and misallocation, the other one of undersupply. But they share the same grave ethical dilemmas I've shown. So I come to the lessons learned. Both the German and the UK health system will fail future generations who will not receive, if they don't change, who will not receive comparable level of healthcare services to those their parents enjoyed. And both systems placed healthcare staff under undue strain. And 2 centuries ago, Karlowitz asked what would happen if trees were not replanted to offset the timber used in mining. Well, at some point, mining operations would simply stop, and with not enough wood, and people could not earn their living. Something similar applies to the German-UK healthcare system. While imminent collapse, as occurred in Bergamo under the COVID-19 impact, for example, is unlikely, even if far-reaching changes are not made. Healthcare system may corrode, and that's where the conference topic fits very well, to a point where they slowly but surely become dysfunctional. This is a development, not an event, but certainly one that no one could want. And preventing that is not an economic but an ethical obligation to become sustainable in the truest sense of the word. However, the old Roman law maxim ultra posse nemo obligato, which means no one is obligated beyond what they are able to do, applies also here, though it will be a long and difficult political endeavor to change a negative demographic trend. One can expect that resources for healthcare will be increased and shifted to where they are most needed, both in Rawlsian and New Testament terms, that is, the least privileged or the sick and the poor, not least those on waiting lists awaiting medical attention and treatment. But even if the resources are made available, how can the problems in recruiting and maintaining healthcare staff be tackled? More and more German hospitals are recruiting staff from Eastern Europe and elsewhere, while the NHS recruitment, according to the BBC, of Ghanaian healthcare workers post-Brexit made international headlines with, in 2022, 1,200 Ghanaian nurses joining the UK's register. Nursing register. Out of sheer necessity, hospital management in both countries I compared has chosen a quick solution, but one that is blatantly unsustainable transnationally, and it's unfair as it's a clear violation of the golden rule in Matthew 7:12, because Ghana, Romania, Philippines, or Belarus are now lacking those nurses. And the UK should do, and Germany should do unto others as you would have them do to you. In this case, that would mean training your own healthcare staff. Or you do it with Iceland, because like Iceland, you are small, you don't even have a medical school, you just train them abroad. So someone else has to run your medical schools. So, coming to a conclusion, 4 points seems relevant if we ask the question, so how do you deal with that? Kant would say, what shall I do? First, give both patients and healthcare staff the feeling and the means that they are not setting sail on a sinking ship, but one that is well maintained and responsibly run. Those who are politically responsible for our healthcare systems should understand that sustainability is not only an economic concept, but an ethical obligation. Second, create working conditions that offer adequate remuneration, professional education development, as well as collegial support. Thirdly, apply the golden rule to hospital management and not only to patients and healthcare staff. Fourth, follow the maxim that no one is obligated beyond what they are able to do. If you expect impossible things from people under stressful and poorly paid conditions, they tend to take the first opportunity to leave. So I close with the path ahead. We have seen two very different systems. And to end on a more hopeful note, I would like to mention a possible pathway of repair, because otherwise, say, I just tell you my wish list with 4 points. Well, what do the comparative studies ranking the various European healthcare systems, not only the NHS and the German, tell us about healthcare systems which fare significantly better in their peers? I should mention now that due to time constraints, I will be unable to address the US healthcare systems, but we can talk about it later. So back to our question, which will I formulate as, where do junior doctors who leave Germany after their first years in medicine, where do they go? And it's just around the corner. It's Switzerland. A 2022 study of 10 countries conducted under the auspices of the Commonwealth Trust reveals that Swiss physicians seem to be the most satisfied at their work. 58% describe that they are very happy with their working conditions, and within the Swiss healthcare system, which 90% rate as good or very good overall. And now the question is, why is that? What do they do right? So without wanting to trigger another comparative study, we might ask, what's their secret? An article in the Austrian Journal of Ethics and Health provides an answer already in this title. The Swiss healthcare system, expensive and good. Unsurprisingly, the key is the generous cantonal funding of the 267 predominantly private hospitals, together with many sensible elements like federalism, liberal choices, innovative daycare models, and a Swiss understanding of direct democracy. So, to conclude, an increase in the funding itself is not enough to solve all those problems. But it's a conditio sine qua non for any healthcare system is sustainable funding. That is responsible funding in the long term, which accounts for demographic trends as they do in Denmark or Switzerland. But at its core, the problem is not only an economic one, but highly ethical one. Sustainable funding must ground an ethical prerogative that benefits those who are called the poor in the New Testament, the least privileged, by Rawls, or simply the patients in any hospital worldwide. So the German philosopher Arthur Schopenhauer is attributed with saying health isn't everything, but without health, everything is nothing. In my talk, I've tried to show that the same applies to healthcare funding. I've also argued that the ethical obligation to reform our respective systems stems from the fact that those most affected by a lack of reforms happen to be the most vulnerable. And because of this vulnerability, it does make an ethical difference if one runs a hospital sustainably or not. And we have seen in the issues raised at this conference, the strengthening of professional identity and compassion, Joshua Horden's work, the moral demandingness of acting against one's conscience, of Alberto Giubilini's work, reflected moral reasons in Compass by Dallas Gingles, and attending to the whole person in Brian Williams as well as Ariel Dempsey's project. We need to do, and church hospitals try to do and work on all of these topics, but if they are running out of funds, they are in the very same situation like any state hospital, between a rock and a hard place. So the economic issue becomes, in the end, if you don't tackle it, an economic disaster. Thank you very much, and an ethical one.